The objectives are to understand the epidemiology of heart failure, including its prevalence, the fact that it increases with age, the fact that there are disparities based on ethnicity. We're going to talk about the workup and the role of markers of risk, including BNP and N-terminal proBNP. We're going to recognize the evidence base and the differing treatments that are recommended for HFpEF, heart failure with preserved ejection fraction, and HFrEF, heart failure with reduced ejection fraction. And we'll talk about the newer drugs that have just been guideline recommended by the American Heart Association in a consensus document that was published this year. Okay, so this is the audience participation. I guess if you have to log into this, because these are going to be case-driven. Okay, so just to start off with, how confident are you in the evaluation and management of patients with heart failure, from not at all confident to very confident, which would be 5, or not at all confident, 1? Okay, so this is an area, it looks like maybe we can move the pendulum a little bit more from slightly to moderately to even more confident than that. Okay, let's move forward. And okay, so let's define heart failure. Heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that either impairs the ability of the ventricle to fill with or eject blood. And the filling is often with preserved ejection fraction. We'll talk about that in detail, or the inability to effectively eject blood, or heart failure with reduced ejection fraction. Regardless of the form of heart failure, the cardinal manifestations are often similar, and they include shortness of breath and fatigue, which may limit exercise tolerance and fluid retention, which may lead to pulmonary congestion, left-sided heart failure, to peripheral edema, right-sided heart failure. Heart failure pathology may affect heart size, wall thickness, and ejection fraction. So on the left is the normal heart. In the middle is a long-standing hypertensive with a preserved ejection fraction 70%, yet signs and symptoms of heart failure. On the far right is the idiopathic dilated cardiomyopathy, large intercavitary volume, but a very thin wall, and this is a reduced ejection fraction. Still presents with shortness of breath and fatigue. So similar presentations, different pathophysiology, different ejection fraction. We're going to see more and more heart failure as we get our patients to live longer and longer. Currently, almost 6 million patients have it, 23 million worldwide. 2.4% of our population in 2012 were reported to have clinical heart failure. The number with heart failure is continually increasing. Up to 2037, we'll have 10 million. It's the leading cause for inpatient hospitalization, and it's the leading cause of recurrent 30-day rehospitalization, and it accounts for 70% of the total healthcare cost of heart failure, that is hospitalization. Total cost is projected to grow. About 20% of patients with heart failure die within the first year of diagnosis, while 50% of patients are dead at 5 years. This is a disease, a clinical presentation that has a worse prognosis than most forms of cancer, but our patients never get that concerned when we tell them that they have a clinical diagnosis of heart failure, and they get very concerned when we use the C word. And if they have class 4 heart failure when they present, they're bedridden, symptoms at rest, 35% are dead within 1 year. Now, we're going to continually see more and more patients with heart failure, and we always see more heart failure in men than women. And here you can see just about 1 in 8 women 80 years of age and older, and 1 in 7 men 80 years and older have a clinical diagnosis of heart failure. And if you look at the ethnicity of the disease, predominantly because blacks have such a high burden of hypertension with preserved ejection fraction, we're going to see more and more heart failure, and blacks have more heart failure than whites, both groups having more heart failure than other ethnic groups. So we have to distinguish, and it's the echocardiogram that helps us distinguish by ejection fraction if the patient has either a preserved ejection fraction or a reduced ejection fraction. HFpEF, HFrEF. And the evidence base for these two forms of heart failure are vastly different. So let's just define some of these terms. HFrEF is defined by an ejection fraction, usually 35%, but always, by clinical trials, 40% or less. It's also referred to as systolic heart failure. Randomized clinical trials have mainly enrolled patients with HFrEF, and to date, only in these patients do we have a vast evidence base for clinical improvement. HFpEF is usually defined by an ejection fraction of 50% or greater, and this can be 70% or greater, meaning 70% of the volume in the left ventricle is ejected at the time of systole. And several different criteria have been used to further define HFpEF. The diagnosis is challenging because it largely involves excluding other potential non-cardiac causes of symptoms suggestive of heart failure. The evidence-based is nil. We do things based on symptom improvement and hoping to use the pathophysiologic mechanism to improve outcome. But as you'll see, we do not have hard clinical trial evidence of outcome improvement other than treat the risk factors, treat the symptoms. Now, patients that have this indeterminate ejection fraction 41 to 49%, you're not sure where they're coming from. So they're what's now labeled as borderline heart failure. These patients fall into a borderline or intermediate group. They have characteristic treatment patterns that are more likely to be HFpEF, but it would be nice to have an old ejection fraction, if one has it, to know where the patient is now. And then there's the improved or recovered EF. These are people, alcoholic cardiomyopathy, beriberi cardiomyopathy, just with thiamine, which can take someone with HFrEF and now make them HFpEF or have an improved ejection fraction and no longer symptomatic. So this is a new category recognized with a subset of patients previously often had HFpEF or HFrEF, and they have an improvement or recovery in their ejection fraction, clinically distinct from those with persistently preserved or reduced EF, and we need further research in these individuals. Heart failure is a syndrome in which there is a adaptive but maladaptive excess in neurohormonal excitation, predominantly from the sympathetic nervous system, and RAS, renin-angiotensin-aldosterone system, on the left of the slide, and an inability within the endothelium to favorably produce nitric oxide that all of us produce when we walk up the steps of this hotel on a cold day when we have to get to the theater because our dinner ran over time and now we have to get to our seats before the theater starts. And we call on the endothelium to release nitric oxide to allow us to effectively vasodilate and respond through cardiac output with the blood flow that we need peripherally. Heart failure has a maladaptive excess of sympathetic and renin-angiotensin, aldosterone tone, and a maladaptive inability to produce nitric oxide. Based on that, we have used ACE inhibitors, beta blockers. If an ACE is not tolerated, an A or B. You can use an ACE and an ARB in clinical heart failure, but the evidence is much less, and the outcomes are improved, but as opposed to in hypertension, we still would rather use one or the other RAS blockers on top of with a beta blocker, and then we have good evidence for a mineralocorticoid receptor antagonist, both spironolactone and eplerenone. In addition, on the right-hand side of the slide, we have evidence for isosorbide hydralazine, and these are two drugs that not only vasodilate, but inhibit the tolerance to nitric oxide utilization, and that is the hydralazine component, which also is a vasodilator. And although we had an ACE neprilysin inhibitor, omapatrilat, that never was brought to market because of the high risk of angioedema, especially in blacks, we now have sacubitril valsartan, which is a combination angiotensin receptor and neprilysin antagonist. And we'll talk about all this as we develop the talk. In terms of biomarkers, when patients develop clinical heart failure and have volume or pressure excess on the left-hand side of the heart, they basically cause an increase in the release of ANP and BNP from the left ventricle, left atrium. This is released into the blood, and it's a marker of volume and pressure excess on the left-hand side of the heart. Although it can occur in many other clinical disease states, it's a very good marker, as I'll show you, in clinical heart failure. It is reduced. Is that my phone? No. It's what? Oh, the wall phone, okay. It's reduced in patients with obesity, and it can be increased, as you can see on this slide, in patients with renal insufficiency. It's not only influenced in cardiac conditions, but also in non-cardiac conditions. Now, it's an excellent prognostic marker as well as diagnostic marker. So it can help you in the diagnosis of clinical heart failure, and it helps you in the prognosis of clinical heart failure. In this particular trial, in patients hospitalized for heart failure, within 6 months, 180 days, you can see in tertiles of BNP, the higher the BNP on discharge, followed on the x-axis, at 6 months, the worse the prognosis in terms of death and recurrent hospitalization. And the lower the BNP, here less than 350, the better the prognosis. BNP and N-terminal proBNP have a class 1 level A evidence base for utilization for the diagnosis and prognosis in heart failure. In ambulatory patients with shortness of breath, measurement of BNP or N-terminal proBNP is useful to support clinical decision-making regarding the diagnosis of heart failure, especially in the setting of clinical uncertainty. But once you have the diagnosis of heart failure, you don't have to be ordering BNPs or N-terminal proBNP, depending on what lab you're using and or what agent you're treating the patient with. That'll make more sense as we talk about this. Because these tests are expensive, and serial BNPs are not helpful unless there's been a change in the clinical course of the patient where it could be helpful. Or if the patient has underlying COPD and heart failure with reduced EF, where you're unsure which is contributing more to their presentation, where the BNP or N-terminal proBNP can be helpful. We break down the stages of heart failure from A, B, C, and D. A and B are asymptomatic, where as primary care clinicians, we're looking to control risk factors that contribute to their disease state. And C and D are symptomatic patients with clinical heart failure, where we're looking to use evidence-based strategies to improve their prognosis and reduce their mortality. We are not going to talk about stage D heart failure. This is often in the realm of the transplant cardiologist or the cardiologist, because these are the people with bedridden clinical heart failure. Hospice may or may not be involved, and for the most part, there's not really that much we can do except work with the hospitalists, try to keep them out of the hospital, and try to keep them comfortable. Most of our efforts are in the symptomatic patient with class C heart failure. We'll talk about that. And we also are involved in the prevention of heart failure. So when you look at the prevention of heart failure, we're talking about lifestyle modification. We're trying to control blood pressure, lipids, perhaps A1C, anything they're doing or taking that can contribute to heart failure. And in general, we use a lot of drugs that modify the RAS system, the sympathetic system, because we're treating hypertension, or we're treating post-MI, where they're still not symptomatic yet. In stage B, the only way a patient still is asymptomatic here, and we're aware of it, is because for the most part, they've had an MI, we've gotten an echo, we know what their ejection fraction is, or they're hypertensive and they've still been asymptomatic, and we have been fortunate enough to get an echocardiogram. But many of our patients with risk factors, because we don't have a clinical indication for getting an echo, will pass through this phase of being asymptomatic. They may have preserved ejection fraction, and it's not until they become symptomatic that we really are able to know what they have at that time. And that's when they have symptomatic stage C heart failure, where the evidence base is extremely rich in reduced ejection fraction, where you have the most evidence for the RAS blocker, ACE or ARB, beta blocker, aldosterone antagonist, isosorbate hydralazine, and some of the newer agents that are out on the market. Okay, and I don't know why this isn't. Okay, so here's the evidence base, class 1 recommendations. In all of our patients, what we should be doing in patients that have clinical heart failure. So these are patients that are presented to us with shortness of breath, with new onset dyspnea, exercise intolerance, bilateral ankle swelling, new onset orthopnea or PND, all of these cardinal manifestations which may be clinical heart failure. You could have prostatic obstruction from prostate cancer with bilateral ankle edema. But in general, you're not going to have shortness of breath or other causes of that would obstruct venous flow and cause bilateral ankle edema. So we're going to get a good history and physical, family history in those for a family history of dilated cardiomyopathy. We're going to weigh them. We're going to have an appreciation of their volume status, JVD, hepatojugular reflex, ankle swelling, orthostasis. The lab tests are not that extensive. A CBC for general health, urinalysis, electrolytes, lipids, liver panel, TSH. We're going to rule out nephrotic syndrome if we can by the amount of protein in the urine, look at their electrolytes, their renal function, their risk factors. Liver panel TSH certainly can be associated with heart failure, both hyper and hypothyroidism. We're going to get an electrocardiogram. Do they have LVH? Is there any AFib? Anything else unusual? Chest radiograph for their volume status. A two-dimensional echo, all class 1 indications, looking at ejection fraction, a BNP or an N-terminal BNP to assess the likelihood of heart failure. We're going to repeat the measurement, all in the 2013 guideline, of BNP or N-terminal BNP when a significant change in clinical status has occurred. So this is a workup that all of us as primary care specialists can do. First case. 75-year-old white woman is here for follow-up. She has a history of diabetes, hyperlipidemia, hypertension, and she's telling you she has mild shortness of breath when walking from her car to church, and she's gained 15 pounds over the past year. She was hospitalized due to poorly controlled hypertension and heart failure 8 months ago, no history of coronary disease. She now has 1 pillow orthopnea, frequent ankle swelling. A past echo showed normal LV function, ejection fraction 70%, and left ventricular hypertrophy. Currently, she's on Amlo 5, metoprolol 50 BID, atorvastatin 20, and a baby aspirin. Her blood pressure is 145/90, pulse is 68, weight 285. No JVD on exam, lungs are clear, cardiac regular rate, positive S4, abdomen is soft, non-tender, and she has 2+ bilateral ankle edema. EKG shows normal sinus rhythm, LVH by voltage, otherwise unremarkable. So, which of the following is most reasonable? Make no changes. Add valsartan 80 BID, add ivabradine 5 BID, add DIG 0.125, or add furosemide 40 BID. Please answer now. Okay. So the most common answer is furosemide 40 BID. Second most common is valsartan. So clearly we want to better control blood pressure. Looks like she's had a history of heart failure with preserved ejection fraction, long-standing hypertension, LVH by echo. We see the voltage changes on EKG. We were fortunate enough to see it on the echo because we're not going to order echoes to rule in or rule out LVH. It's too expensive, but it's a very sensitive test for LVH, the echo. The EKG is not very sensitive, but it's specific when we see it. So I think you all got the right answer, and that is add furosemide 40 BID. So in this 75-year-old woman with shortness of breath and edema, recent hospitalization for uncontrolled heart failure and hypertension, she has HFpEF, heart failure with preserved ejection fraction. We treat the symptoms. We make her feel better. There's a need for cautious diuretic therapy with potassium supplementation if necessary. When you try to distinguish HFpEF from HFrEF, as was done in a New England Journal article, it is very difficult, unless you know the ejection fraction, to differentiate these two forms of heart failure, because they all present, HFrEF and HFpEF, with pulmonary rales, fluid overload. They can present with dyspnea on exertion or at rest, PND, inability to sleep, daytime fatigue, loss of appetite from gut edema, and difficulty concentrating, reading, and calculating. The best tools to differentiate these are HFpEF S4, HFrEF S3, HFpEF narrow heart, HFrEF dilated heart, HFpEF, and those are basically the distinguishing factors. So if you didn't know what the ejection fraction was and you saw them in the emergency room, the history is really going to help you differentiate the two. A couple of things on physical examination are going to help you differentiate the two, but otherwise you can't differentiate the two, and it's imperative to do so. Almost half of patients with heart failure, clinical heart failure, have HFpEF. Risk factors are advanced age, female gender, underlying hypertension, diabetes, LVH, often from hypertension, with or without coronary disease. It has a predilection for women. Eric Topol from the Scripps Clinic in 1987 in the New England Journal had a paper called The Hypertensive Hypertrophic Cardiomyopathy of the Elderly. Predominantly women, mostly all with hypertension. These were people that presented to the emergency room with a new form of heart failure, hypertrophic cardiomyopathy. These were thickened left ventricles, often with concentric LVH, women more than men. Hypertension as an underlying etiology. It accounts for half of all hospitalizations for heart failure, and the mortality rate is half of that with HFrEF, but greater than those with normal heart function. If you look at the Framingham Heart Study, the Mayo Clinic in green, CHS data, the Framingham data in yellow, a little orange, California Medicare data, or the Duke Registry, about half of all heart failure is preserved ejection fraction. We used to use this term diastolic heart failure, but because it's a very sensitive differentiation, clinical trials have enrolled people by their ejection fraction. So what we do for our patients is based on their ejection fraction. And most people with HFpEF have diastolic heart failure, okay? And most, if not all, patients with diastolic heart failure have preserved more than reduced ejection fraction. So we base this on clinical trial data. If you look at the prognosis, it's not normal as in control, but it's about half systolic heart failure. So there's a price our hypertensive pay for bad control of blood pressure over many years, but not nearly as poor a prognosis as those with HFrEF from whatever etiology, be it long-standing hypertension or coronary artery disease or dilated cardiomyopathy with normal coronaries, etc. If you look at admissions, they're about equal. They're about equal. So many of our patients, half of our patients admitted to the hospital have good ejection fractions, poorly controlled risk factors, and that's why they're admitted to the hospital. If you look at slices of the heart, in the middle are normal hearts. On the left is the patient I presented to you with that long-standing hypertension, how well has your hypertension been controlled over your clinicians treating you? Well, doctor, honestly, I've never really had well-controlled blood pressure. Thickened, concentric, left ventricular hypertrophy. Look at the muscle of that left ventricle. And that heart pumps so hard to get blood out, but pumps effectively. But as I'll show you, when blood is in that left ventricle at rest, that patient develops an inordinate pressure, and if they're not careful, they will develop signs and symptoms of clinical heart failure. On the far right is the dilated cardiomyopathy, ejection fraction 20%, but has a thin wall with a large intercavitary left ventricle from a dilated cardiomyopathy. So what's going on in our patient that I presented to you? Well, here's how you get symptoms, and normally you and I are going to watch a football game, have a few friends over, so we're on the Frank-Starling curve, and we take in some beer, we take in some potato chips, we take in some excess salt, for instance, and our volume goes up, the pressure goes up, but we go to the bathroom before we ever have any symptoms. And we now fall back on the Frank-Starling curve from here, oh, I can't show you, but to the right, now down to the left. On the other hand, our patient with concentric LVH does the same thing, and for the same amount of volume, they develop an inordinate pressure, cross that threshold, and get fullness and congestion from the left side of the heart, which is translated through the liver to the right side of the heart, and they get short of breath through their pulmonary circuit. And they may or may not have edema, but they go to the emergency room because they're having difficulty breathing. So what has put our patient over with HFpEF into clinical heart failure? Well, this is a good exercise because these are the things that do it. Has Mrs. Jones now consumed excess salt? Did she develop new onset AFib and lost the atrial kick? Has she been on a recent NSAID or a rate-limiting CCB? Does she have an inadequate diuretic regimen? Worsening hypertension, superimposed myocardial ischemia, worsening renal function, iatrogenic volume overload, or superimposed anemia. And all of these things are a nice checklist for our patients who have risk factors and now present or represent with HFpEF. On the far left of this slide are all of the clinical trials that have given us our evidence base for why we're so good at treating people with HFrEF, and the clinical trials on the right that have not shown any benefit compared to placebo in the drugs that have been studied for mortality, including DIG, candesartan, perindoprel, an ACE inhibitor, irbesartan, aldactone, and aldactone. So rich in our evidence base for HFrEF, limited in our evidence base for HFpEF. And for HFpEF, we come down to treating their signs and symptoms and improving their hemodynamics. That's why Lasix was the right answer for our patient. So randomized clinical trials have not shown a survival benefit with any particular drug therapy in patients with HFpEF. What do? We control their blood pressure. We use careful diuresis to control their symptoms of edema and or shortness of breath. So the answer, valsartan, might have been a good one to better control the blood pressure, but the reality is, initially, we're going to use a diuretic, and if we use a loop diuretic, Lasix, we're going to use it BID in heart failure. And once that pressure comes down and that volume excess gets reduced, we may be able to back off and will be able to back off on the diuretic, and we may then backfill with better blood pressure therapy. But something happened to this woman to put her into this acute on chronic state of HFpEF. What's the evidence base suggests? We have a class of recommendation, 1, for controlling blood pressure and relief of symptoms with diuretics for volume overload. This is all for quality of life. We have no mortality reduction in any trial we've ever done in HFpEF. And then we want to make sure there's no superimposed ischemia. new onset atrial fib. There's a 2A recommendation. Makes sense to do it, and it is recommended. Much better than any negative effect or deleterious effect for suggesting beta blockers, ACEs, or Arbs to treat the hypertension, and Arbs might be considered to decrease hospitalizations in HFpEF. Okay. Let's move on. Case 2, 68-year-old African-American woman for follow-up visit. History of non-ischemic cardiomyopathy and hypertension. Has to rest daily during housewife due to shortness of breath. Has 1 pillow orthopnea. Was hospitalized 6 months ago for heart failure. No history of coronary disease when cathed a year ago. 6 months ago, her echo showed an EF at 30% with a dilated cardiomyopathy. Currently on valsartan 160 BID, carvedilol 25 BID, furosemide 40 BID, spironolactone 25 a day. She had angioedema to enalapril. Physical examination revealed blood pressure 125 over 80, pulse 62, weight 255, lungs are clear, regular rate, 2 over 6 systolic murmur, abdomen soft, non-tender, 1+ edema. Question, which of the following is most reasonable? Make no changes, add enalapril 10 BID to the valsartan, add ivabradine 5 BID, add isosorbide dinitrite hydralazine, or discontinue valsartan and add sacubitril valsartan 24-26 once a day now. So we only have 5%. Okay, somebody wants to make no changes. Okay, so isosorbide hydralazine is the most common answer, and that's the answer that I thought was best. So here's a patient with a dilated cardiomyopathy, superimposed symptoms on top of a reduced ejection fraction, HFrEF, African American. Angioedema to enalapril, which would not allow you to use sacubitril valsartan, because angioedema is a contraindication. And this drug is given BID, not once a day. So answer 4 is the best. So our patient has New York Heart Association class 3 heart failure, moderately symptomatic, recently hospitalized. We need to evaluate for ongoing new symptoms, optimize evidence-based therapies, reduce any recurrent hospitalization, and improve her survival. The patient has persistent symptoms despite optimal neurohormonal blockade with an Arb beta blocker and mineralocorticoid receptor antagonist, and fixed-dose combination isosorbide hydralazine should be added to her treatment regimen. It's the best evidence-based guideline treatment recommended for this African-American patient with class 3 HFrEF. So let's look at the evidence for why we do what we do in HFrEF. Symptomatic HFrEF, stage C HFrEF. We have ACEs or Arbs, we reduce death, the NNT is very generous, and we reduce hospitalization, all significant from clinical trials. Beta blockers, we reduce death, NNT is very favorable, and we reduce hospitalization. We add an aldosterone antagonist, we reduce death, the NNT is favorable, and we reduce hospitalization, and at least in African Americans, self-identified African Americans, hydralazine and nitrates reduce death, and this is on top of the background therapy above it, have a very favorable NNT and reduce recurrent hospitalization. What an evidence base for us to use in these patients with heart failure with reduced ejection fraction. And going back to the slide I showed you earlier, we're antagonizing the renin-angiotensin-aldosterone system, ACE or ARB, beta blocker, and mineralocorticoid receptor antagonist, and we're trying to upregulate the deficient nitric oxide system that African Americans have more negative effect, more inhibition than non-African Americans from basic science work. Just some practical points on ACEs and ARBs in heart failure. We initiate one or the other at low doses. We titrate up to the doses used in clinical trials. We use with a beta blocker, and the evidence suggests an ACE or an ARB with a beta blocker is better than the highest dose ACE or ARB as monotherapy. So if blood pressure is low and you have no blood pressure room to add more drug, I'd rather see you use a little ACE or ARB with some beta blocker than just an ACE or an ARB. And I think the evidence supports that. We have some caution based on systolic blood pressure, serum creatinine, serum sodium, and potassium. In general, we're not going to add ARBs to ACEs. We're going to add one or the other, add the beta blocker, add the aldosterone antagonist. Okay. If you look at beta blockers as opposed to ACEs or ARBs, we believe there are class effects for benefit. Only 3 beta blockers have been used in clinical trials to show evidence. Here, reduction in death, total death. Toprol XL, that is the long-acting metoprolol succinate. In the middle, bisoprolol, used in Europe, not used much here. And on the far right, carvedilol, or Coreg. These are all evidence-based beta blockers. So it matters with the beta blocker which one you use. I would rather you not use metoprolol tartrate, the BID metoprolol. All of these are generic drugs. All of these are inexpensive drugs. And the long-acting metoprolol has evidence where the BID metoprolol tartrate in heart failure does not. We like the mineralocorticoid receptor antagonists, spironolactone and eplerenone. Spironolactone has a very long half-life, only has to be given once a day. We tend to use it at a ceiling dose of 25. Rarely would we have to go in heart failure to 50. The problem with adding these drugs to a RAS blocker, ACE or ARB, is the 4.5-45 rule. So we don't want to create hyperkalemia. And so if the patient's K is less than 4.5 and the renal function is favorable, 45 or greater, we're not going to get into trouble by adding one of these drugs. Otherwise, there are new drugs on the market that are potassium binders, and I don't have time to get into those, but we are going to start, I think, to use those to give us some room with the potassium if that is an issue, because these drugs prolong life. We want to minimize hyperkalemia. So in terms of the hydralazine and isosorbide, we look at this algorithm. Our patient is a stage C HFrEF. We've got them on the ARB and the beta blocker. They are African American. We've already added the aldosterone antagonist on the far right, and now we're going to add the FDA-approved hydralazine and nitrate. And we pull the AHEF trial. This is the African Heart Failure Trial, New England Journal, 2004, which double-blindly compared placebo to isosorbide hydralazine in African Americans with class 3 or 4 heart failure, HFrEF, on standard therapy. Excellent background therapy. 94% were on diuretics, 78% were on an ACE or an ARB, 87% were on a beta blocker. Yes, digoxin still has a place, but it's much lower than when many of us learned about heart failure, where all we had was dig and diuretics. So in the 80s, we got the ACEs. We learned that the beta blocker was not the devil in HFrEF, and we started using that. Then in the 90s, we got the ARBs, and we were learning how to use these drugs in heart failure with reduced ejection fraction. So DIG, which reduces hospitalization, recurrent hospitalization, but does not do anything for mortality, and doses that are less than we used to use in the 70s and 80s still may have a place, but it's a much lower place because it does nothing for mortality. And spironolactone, which our patient was on, and these patients in AHEF was on, I already showed you, also reduces mortality in HFrEF. So here's the New England Journal study. Here's the data. Compared to placebo, there was a 43% significant reduction in death rate, and there was a benefit in quality of life on the far right and hospitalization. So it's very favorable for its evidence base as an additive strategy in African Americans. It's the first drug the FDA approved in African Americans for heart failure. It can be used in non-African Americans, but Caucasians don't quite have the attenuation in the ability to upregulate nitric oxide as African Americans do, but it can be used. So it's got a 1A recommendation, the combination of hydralazine and isosorbide in African Americans with New York Heart Association class 3-4 heart failure on guideline-directed management therapy, which our patient was on. It can be given in a fixed-dose combination pill that comes as a single pill, or it can be used as 2 generic pills using both hydralazine, which attenuates the nitrate tolerance that can occur with TID isosorbide dinitrate. So very nice points on using this combination in clinical heart failure. Okay, let's move on. 56-year-old white male here for follow-up. Dilated cardiomyopathy, HFrEF, generally well, but continues to have shortness of breath when climbing 2 flights of stairs. No history of coronary disease, continues to have increasing orthopnea. Blood pressures 110/70, heart rate 59, no JVD, lungs clear, no S3, no edema. Currently taking lisinopril 40, carvedilol 12.5 BID, and spironolactone 25 a day, Lasix 20 BID. Physical exam, good blood pressure, heart rate 59, no JVD, lungs clear, cardiac regular rate and rhythm, abdomen soft, non-tender, and no edema. So, question, which of the following is most reasonable? Make no changes, add valsartan 40 BID, add ivabradine 5 BID, add digoxin 0.125, or discontinue lisinopril and add sacubitril valsartan in 36 hours. Now, this patient tells you that they're having more shortness of breath than they had in the past. You could get a BNP if you had one in the bank, an N-terminal BNP. It'd be nice to have. And I can tell you that they're higher, significantly higher, concerningly higher. So I don't want to be overly critical, but for those that said made no changes, I should have said at least refer to a cardiologist, because something's going on for this patient, and we're just not going to do nothing when we can do something. And we have tools in our armamentarium that can help this patient. And 78% of you got the answer that, in this case, I also think is the best situation, and we'll go through the evidence base here. And that comes from a recently published study on the use of sacubitril valsartan, angiotensin receptor blocker, neprilysin inhibitor, directly compared to enalapril in heart failure. So how was it done? It comes from the Paragon Heart Failure Trial. Yes? No. This was an African-American patient with HFrEF on good background therapy who was telling you, she still had shortness of breath, orthopnea, couldn't do her chores in the house. She wasn't on any hydralazine. In this case, yes, I think you could, but this is a Caucasian patient, and I think the best answer, and I'll show you why. So what I'm creating is a clinical case, multiple clinical cases that tell you there are branch points for why we do what we do to help the individual patient. In this one, you'll learn that you wouldn't add the ivabradine because the heart rate's 59. And there's no history of angioedema here or any contraindication that I told you about that wouldn't allow you to add the sacubitril valsartan. You wouldn't just make no changes because this patient is telling you, I'm having new symptoms. And you could say, well, you're overweight, you're fat, and you're ugly, and you don't exercise, so you're just, out of shape. But the reality is, you could have, and I didn't tell you, you could have maybe gotten that BNP or N-terminal proBNP, and it's strikingly higher, even though you didn't see anything on physical exam, and you want to do something for this patient. Now, this is a trial industry-sponsored by the makers of sacubitril valsartan, in which patients that were on enalapril, were on an ACE inhibitor or an ARB, for a minimum of 6 weeks were were open-labeled challenged with enalapril, 5 to 10 BID, then taken off that, sacubitril valsartan, 100 BID going up to 200 BID, which is the ceiling dose of this particular drug. So during those 6 weeks, tolerability was achieved in all the patients eventually randomized. And then those patients who tolerated enalapril and tolerated sacubitril valsartan were double-blindly randomized to the combination drug or enalapril 10 BID. And they were followed for several years, and hard outcomes were evaluated. And you can see the primary outcome, multiple secondary outcomes, including all-cause mortality. When you look at the patients, the mean age was about 64, a fifth are females. 3/5 have ischemic cardiomyopathy, coronary disease. Ejection fraction, HFrEF, 29%. Most of them had class 2 heart failure, some had class 3. Very few had class 4. You see their blood pressures, these are the means. You see their N-terminal pro-BNP at baseline, and you see their BNP. Normal BNP is usually less than 50. We use 100 as a threshold for a diagnosis of heart failure. Usually heart failure is much, much higher, and it can be in the thousands when they're acutely presenting to us. A third were diabetics. Look at the background of therapy, well treated. They're on ACEs or Arbs, and that's interesting, I'm not sure. Look at the beta blocker penetration, the mineralocorticoid antagonists. Of course, they were on an ACE or an ARB, all of them by definition, correct. Not quite a third on DIG, 8 out of 10 on a diuretic, and some of them had device therapy, okay, cardiac defibrillator or cardiac resynchronization therapy. So what happens to these patients? Well, double-blindly, when you compare the patients, the primary endpoint significantly reduced 20%. Death from cardiovascular causes is reduced 20%. Hospitalization for heart failure is reduced 20%. And death from any cause, 16%, all significant. In a model that looked at the trial, it stated in this reference, a 55-year-old would have a projected life expectancy of 11.6 years with enalapril BID versus 1.3 years further with sacubitril valsartan, assuming the 20% event rate reduction. So that they're living 1.3 years more. When you look at how the drug works, so here you see in pink there, the sacubitril valsartan, it's also known as LCZ696. Clearly, sacubitril is a neprilysin inhibitor, so it inhibits the breakdown of BNP and N-terminal BNP. In addition, neprilysin also has an off-target effect of inhibiting the breakdown of angiotensin II. So it upregulates angiotensin II, and that's why you have to give it with an angiotensin receptor blocker. So you're going to block the effects of the upregulation of A2 by blocking the receptor, the angiotensin type 1 receptor, and you're going to end up with an upregulation of the vasodilatory hormones, BNP, ANP, and you're going to get a reduction in blood pressure, sympathetic tone, aldo levels, fibrosis, hypertrophy. You get natriuresis and diuresis, and you block the vasoconstriction, which leads to vasodilatation and all the effects of the ARB. But what happens to the patients? Well, it's FDA approved to reduce the risk of cardiovascular death and hospitalization for heart failure in class 2 to 4 heart failure with HFrEF. You start with 4951 twice daily. It's a BID drug, and the target dose is what ended up as 200 BID, but it's 97 of sacubitril, 103 of valsartan. And this correlates with the 160 BID dose clinically that we use of valsartan as a single agent. And if they're ACE or ARB naive, or on a low dose of an ACE or an ARB, or have severe renal impairment or moderate hepatic impairment, we're going to start with lower doses, 24, 26 twice daily. But for the most part, we're going to use the moderate dose, the 4951, in patients that have been on an ACE or an ARB. But if they're on an ACE inhibitor, we have a 36-hour washout before we start the sacubitril valsartan. And it can't be used in pregnancy. It can't be used in breastfeeding. We don't use it for acute decompensated heart failure. We watch blood pressure, potassium, creatinine very carefully. We do not use it if they have a history of angioedema. And the most common side effects were hypotension, but hyperkalemia was not significantly different. Renal impairment was greater for enalapril. Nevertheless, we monitor the systolic pressure, potassium, and renal function. And angioedema is more likely to occur in blacks like it is with an ACE or an ARB and patients with a prior history of angioedema. So it's contraindicated in patients with a prior history of angioedema. Of note, this particular drug, sacubitril valsartan, causes an increase in BNP. So for this drug and this drug only, we will follow N-terminal proBNP. For this drug and this drug only, we need to follow N-terminal proBNP if we're going to use that as a marker of prognosis, how the patient's doing. So in the focused update, they're now giving a little bit more on the level of evidence. And let me just say that this has a class of recommendation, class 1. And this is some of the controversy. If the patient is, first of all, the ACE or the ARB has the highest level of evidence, and this drug, the ARNI, the angiotensin receptor neprilysin inhibitor, has a BR recommendation. So it's a level of evidence B, and it's one randomized trial. Nevertheless, the FDA has given it an indication for reducing cardiovascular death and recurrent hospitalization in class 2 to 4 heart failure, although most was 2 to 3, in patients that are currently on an ACE inhibitor and have continued symptoms. And that's exactly how the drug, it's hoped that the drug will be used. So it's a drug that could be used when patients are already on an ACE or an ARB, but not both, continue to have symptoms. And if they're on an ACE inhibitor, you wait 36 hours, you don't use it in angioedema. It costs, in the medical letter, $375 a month. So it's a pricey drug. And hopefully it's available to us if we need to use it. The question is, would we write it? Would the cardiologist write it? And will it be used? Interesting. But it's nice to have more things available to us. And then finally, this is case 4, 76-year-old white male, history of coronary disease, ischemic cardiomyopathy, reduced ejection fraction, history of COPD with frequent use of inhalers, comes to see you following a recent hospitalization for decompensated heart failure on lisinopril, metoprolol 12.5, aspirin, atorvastatin, albuterol inhaler. There's the blood pressure. Patient has wheezes in the lungs. You're concerned about COPD, has been having shortness of breath, has a pulse of 85, EKG shows sinus rhythm, nonspecific STT wave abnormality. So which of the following here is the most appropriate? Make no changes, stop lisinopril, switch to enalapril BID, add ivabradine, add isosorbate hydralazine, discontinue lisinopril sacubitril in 36 hours. And here, because the heart rate is so high and the patient has an inability with wheezing to tolerate a more effective dose of beta blocker, this is another new drug called ivabradine, available in Europe since 2010. High resting heart rate, severe COPD. You get a BNP. It's higher than the baseline BNP or the last BNP when they were discharged. So the COPD contribution is not as great as the heart failure with reduced EF. And here you would consider ivabradine. This is a pure rate-limiting drug which works on the so-called funny channel, which reduces heart rate, has no effect on blood pressure, on intraventricular conduction, or anything else, just on the heart rate through the sinus node. And basically, it delays the action potential duration, thus reducing heart rate. It's been looked at in this study called SHIFT in heart failure with reduced ejection fraction, up titrating from 5 BID to 7.5 BID versus placebo for cardiovascular death and hospitalization. Bottom line was it was a significant trial, NNT 20, no effect on cardiovascular death. So it is a drug that reduces heart rate in those with a heart rate of 70 or greater, and in the trial, those with a baseline heart rate of 77 or greater had the greatest benefit. It keeps people out of the hospital when you can't up-titrate the beta blocker and you can't get rid of the COPD component. So that's where it has its real efficacy. And it's FDA approved in HFrEF, normal sinus rhythm, heart rate 70 or greater in patients taking beta blockers at maximum tolerated dose, guideline recommended or highest tolerated dose. And it has not a 1 class of recommendation, but a 2A. So it's lower, and it's only 1 study, so it gets that BR, 1 randomized trial. ACE inhibitors have 12 trials. ARBs have 7 trials. Beta blockers have 3 trials. These new drugs have 1 trial. But we have new drugs in our armamentarium. 2A, BR, if the heart rate is 70 or greater, sinus rhythm, continued symptoms on good background therapy. Do not use in patients with acutely decompensated heart failure, in those with hypotension, when the resting heart rate is less than 60, but it has to be 70 or greater to start the drug. And it can be associated with bradycardia, with elevations in blood pressure, with new onset AFib, and with what's called phosphenes. These are luminous phenomena, not scotomata, but people on this drug initially, which dissipates over time, feel a light sensation, a bright light sensation associated with the drug. It's called a phosphene, and it goes away over time. So this is an algorithm from the European Cardiology Society that is 2016, and it basically incorporates all of these things. And in green is the class 1 recommendation, and in yellow is the 2A. Notice that they're saying you can use sacubitril valsartan, but ivabradine as a 1 level of evidence, but ivabradine has a 2A level of evidence. So a lot of information, going over it very quickly. In summary, heart failure has a high morbidity mortality. Hypertension is the most likely risk factor to be associated with heart failure, HFpEF. Current treatment of heart failure is both empiric, we use diuretics and lifestyle, especially for HFpEF, and evidence-based, ACE or an Arb, beta blocker, mineralocorticoid receptor antagonist for HFrEF. They reduce mortality, they improve quality of life, and they keep people out of the hospital. In addition, newer therapies, including ivabradine and valsartan sacubitril, have been approved for HFrEF and can be added to our significant evidence base for outcome improvement. The Paragon Trial, I talked to you about the paradigm with HFrEF, but the Paragon Trial is ongoing right now, and it's looking at sacubitril valsartan in HFpEF. Sacubitril valsartan in studies in hypertension have significantly reduced blood pressure over placebo. But the makers of this drug will not bring this drug to market for hypertension in our country. They will do so worldwide, but not here. But they're looking at it in HFpEF, and there's a lot of excitement. Remember, I told you there's no good evidence base for a particular drug that improves or reduces mortality and improves longevity in HFpEF. Stay tuned. Perhaps this combination of drug that antagonizes the RAS system and favorably upregulates the natriuretic peptide system will have a benefit.